Want me to start?
Yeah.
Okay. Sara Marasco. Nice to see all of you. Lots of familiar faces. So bright. So I'm still working at U of M in the Department of Psychiatry. Like Kathy said, for several years I worked as part of the TAMS project, which is our collaborative care pilot that kind of got the BHCC program going, which some of you are part of and many of you are probably familiar with. I am currently working on kind of a wider scale collaborative care implementation project. We're helping to implement it in community health centers throughout Michigan now. So kind of teaching others to do what we've been doing at Michigan for several years now. And in terms of SBIRT, I have a lot of experience delivering SBIRT in primary care settings as part of that role, and lots of experience with motivational interviewing as well, which is a huge part of SBIRT. I mean, really, I think the most important part. So I trained in motivational interviewing in the emergency department, and for a year I delivered brief motivational interviewing-based alcohol intervention for risky drinkers that came into the ED, and received a lot of good training under lots of good folks in the Department of Psychiatry, and continued to do motivational interviewing throughout collaborative care. And actually just recently got accepted to MIT, the Motivational Interviewing Network of Trainers. So I'm excited about that. I think that's pretty much everything. Go ahead.
I'm Teague, Simoncic. I started my social work career with the TAMS project in the Department of Psychiatry. I was our coordinator, so doing a lot of the back-end organizing training, things like that, and doing our evaluation. In 2016, I moved over to IHA to be a behavioral health care manager in the collaborative care program. So actually doing the work that I've been talking about for the last few years. I'm in a primary care clinic in Ipsy right now, doing a ton of motivational interviewing, which is a piece of SBIRT, and also using SBIRT techniques to talk to folks about their risky substance use. And I will soon be transitioning into a hybrid care manager, trainer, educator, preceptor role, helping to train and work with our incoming folks. So very glad to be here, glad to have more of the cross-system collaboration. Let's get started.
Awesome.
And one thing to note too, this is going to be less of a lecture because those are kind of boring, and more of a conversation, we hope. So it's not like, okay, save all your questions for the end. If you have a question, feedback, raise your hand, let us know. Let's keep that dialogue going too.
Yeah, and we have folks on Blue Jeans, so hopefully they can hear us okay. We have some of our community health center partners joining us from throughout Michigan. So hopefully they can see everything and hear everything.
So we want to know who is in the room. So raise your hand if you're U of M. Yep. IHA. And who sees patients with substance use or alcohol use issues? Great. Yeah. Is there anyone who didn't raise their hand? And who is familiar with SBIRT?
That's familiar. Who practices SBIRT? Okay. And I bet more of you are probably practicing it than you realize. We'll see. We can kind of reassess at the end of it. I think the first time we were trained in SBIRT many years ago, we went through the training and we're like, oh, we actually are, we're doing that. Yeah. But this just kind of provides a more formalized structure, and, some of the motivational interviewing techniques can be, a little more in depth potentially.
Speaking of motivational interviewing, who knows what that is or is familiar with that?
And who is practicing motivational interviewing on a regular basis? Great.
About half of you-ish,
maybe a little bit more. Great. Wonderful. Thank you.
So we know, we won't spend a ton of time on this because everyone kind of knows the risks of risky alcohol and substance use, but it's important to talk to our patients about substance use. We know that 20% at least of primary care patients are reporting risky drinking, a huge increase in ED visits involving misuse or abuse of prescription drugs, and we all know that substance misuse, and when we talk about substances, we're talking about alcohol, prescription drugs being used in a way that were prescribed, illegal or illicit drugs, even tobacco. We all know that misuse of them can be related to health concerns, mood disorders, And we've got some new prescribing guidelines that you have probably all become familiar with lately, that are requiring docs to at least start having these tough conversations.
Have you all noticed any impact on your work yet from the new prescribing guidelines that have come down? Any changes in your interactions with patients thus far? And if so, what does those look like? Go ahead.
I work at the clinic, so with all the prescribing, that I just know it's starting to kind of roll out. One of our providers, yes, the more and there's not a lot of activity, and that's happening down. That we're getting information, they're interacting with.
Yeah. Okay. Lots of uncertainty on their part, which maybe causes some discomfort and and maybe impacts your work too. Okay. Anyone else? Great. So yeah, like Teague said, we know that it's important to talk to our patients about substance use, and additionally, research shows that patients actually do want to talk to us about substance use, which maybe feels a little bit surprising sometimes. So we won't go through all of these in depth, but essentially what we can gather from this is that if patients are asked about it, most of them are saying that they're going to be somewhat honest. They're going to want to talk about it. They feel that they should be talking about it and should be asked about it. And they wouldn't really necessarily be annoyed or embarrassed if they had to bring up any kind of their substance use. So it's something that essentially should be on the table per what the patients are telling us. But oftentimes a lot of us don't know how to talk about it, or if we do talk about it or if we do bring it up, we don't really know what to do with that information. And that might be some of us in the room. It might be more physicians or, other providers. But yeah, so does any of this feel surprising to folks in terms of the percentages?
Yeah, I think some not. These stats are surprising to me too.
Me too. Absolutely. Sometimes it feels like we get quote unquote resistance from folks, but it's a little bit more complicated than that, which we'll talk about more today.
It seems like it goes against that idea that we always double the amount of alcohol that our patients tell us they drink. So if we've got 92%, like I'm going to give an honest answer, yet like I feel like our conventional wisdom is like double whatever.
Right. So who knows, what this data tells us, and but good point. Yeah. We get a little cynical sometimes, maybe. Okay.
And we also know, despite the fact that it's important to talk about this and that patients are seemingly wanting to talk about this, we are not talking about it. We're missing opportunities to have these conversations. So when some physicians were surveyed, they reported they don't know how to treat substance disorders, and it's not as satisfying for them, partially because they're not quite as familiar. And we also know that screening tools, which can help us start to pick out who are folks that we should be talking to about their risky use, we're not always using those screening tools. And then even if we are screening for substance use, we're not always talking about that too. So there are a lot of opportunities that just are missed. Do you all think of any other opportunities that you might be in where you could be talking about risky substance use, but you're not?
Or providers that you work with, like where you see it slip through the cracks.
It seems like more often there's not a lack of intention to talk about it myself, but I'm thinking of one particular person who does have a clear relationship with one. And but she's also got a lot of other stuff going on. So when she comes in, I may intend to be asking about her use, but we end up talking about a big crisis that's not related. And it's a source of frustration to try to keep that focus, even spend a couple of minutes in every session.
Absolutely. I saw some head nods with that. It's a bit of a dance sometimes where there's this thing that we should be addressing, and at the same time, it's what the patients bring to the table too. So we don't want to neglect what they're there for.
Yeah. These issues aren't So like, okay, I have one patient and they just have this one issue of their use of wine, or this one issue with whatever else. It's not that clean cut.
Yeah, that's a great point. So we kind of do what we can, and I think, you know, when we talk about the SBIRT model, sometimes when you look through the SBIRT model, it almost is described as like an ideal situation. Like, great, we're going to go through the screen, we're going to do the brief intervention, it's going to be clean, and we're going to tie it up with a ribbon. But it's not always like that, and so I'm glad you brought that up. It can vary, and we'll talk about some of the nuances as we go through, and like, you know, how it can still be effective and still be helpful, even if we do a shortened version of it. Great. So, SBIRT. If you weren't aware already, it stands for Screening, Brief Intervention, and Referral to Treatment. It's been around for quite a while, the early 2000s, from what I'm aware of. And it's very evidence-based. Like it says here, a top-ranked preventative and integrated public health approach, and it delivers early intervention and treatment services to people both with and at risk of developing a substance use disorder. So we'll talk about that, but kind of it's appropriate for folks all along the spectrum, depending on where they fall on the screening. So this is sort of like the general structure of SBIRT. You put together this cute little flow chart.
I love a good flow chart.
So in SBIRT, we'll talk about each of these components, but a big part of it is pre-screening patients to determine if they are at any level of risk. If they do indicate that they are, you move into a full or more lengthier screen to determine kind of what their substance use really looks like. And then depending on where they're at in terms of hazardous use or risky use, that will determine whether you're going to do a brief intervention or a brief intervention plus a referral to treatment. Okay, we'll go through these in more detail, but basically SBIRT, it has a lot of benefits. I'll list them off here. So it's well known to reduce healthcare costs. Per cost of patient, it can save health systems tons of money. It's known to reduce the severity of drug and alcohol use. It can reduce the risk of trauma. It can reduce the percentage of at-risk patients who go without specialized treatment. So it's getting people to where they need to be, essentially. And it can reduce the number of ED visits, non-fatal injuries, hospitalizations, arrests, and motor vehicle accidents. So lots of stats. Essentially, it reduces risk, keeps people healthier, keeps people out of the hospital, and away from injury a bit more than if you weren't to do SBIRT with them. Okay. And essentially, and we talked about substance use. Okay, great. So just a quick stat here, again, to drive home that SBIRT's helpful. So people who receive screening and brief intervention in an emergency department, hospital, or primary care office experience 20% fewer emergency department visits, 33% fewer non-fatal injuries, 37% fewer hospitalizations, 46% fewer arrests, and 50% fewer motor vehicle crashes. It's a mouthful. Again, it's helpful. And it's effective in a variety of settings. So I think we're kind of curious about what settings you all work in here. We have quite a variety, but we know that it can work, it's generally for medical settings, but we know that it can work in primary care, community health centers, specialty medical practices, including like HIV clinics, emergency departments, workplace wellness programs like EAPs, behavioral health settings, whether that be inpatient or outpatient psychiatry, collaborative care, et cetera, school-based settings, including health centers, as well as geriatric sites. So it works with folks of all ages, including adolescents. There's some evidence there.
Does anyone work in a setting that's not here on the screen? Great. So just as there are a spectrum of use patterns or use behaviors, so you've got on the one end, you've got your patient who never drinks, never smokes, never does drugs, whatever. And then we are all the way over on the other end of dependence. And a lot of folks are somewhere in the middle. Mm-hmm. So just like there's a lot of different use patterns, there are a lot of different interventions. So all the way from prevention and education to that formal specialized treatment. So SBIRT, again, is somewhere here in the middle too. Yep.
And just a comment on the word brief advice. I feel like I have a gut reaction to that, being somebody who practices MI. So we'll talk about how to provide information in sort of a friendly MI-based format within this model. So again, motivational interviewing plays a big role in SBIRT. This is just a brief preview. We're going to go to it later on in our presentation today. And we're just touching here on the things that essentially make up the spirit of motivational interviewing. So partnering with our patients, really kind of looking at our collaboration with them as a dance rather than a wrestling match. So we want to be their guide, but we don't want to be their teacher, if that makes sense. Like they're the expert, they have the information that they need to change, and we're just kind of helping to lead the way. Acceptance, so really we know that when we foster an environment of sort of unconditional positive regard, Rogers tells us that if that environment is created, that patients will want to move naturally towards like self-actualization, which they're probably familiar with. So if we can foster this environment of acceptance, generally people are going to want to, change and make the healthiest choices for themselves possible. Compassion is really big. Interestingly enough, that was added somewhat recently into the spirit of motivational interviewing, not until the 3rd edition, just to ensure that our hearts are in the right place, meaning that, we aren't making choices for patients that we think are best or that we think are going to serve them the best, but rather we have their best interests at heart. So we're really listening, and again, remembering that they're the expert. And then evocation. So what that means essentially is that we aren't telling the patients why they need to change. So if a patient has asthma and they're smoking, that might be why we think they need to change, because clearly you're hurting your health, but that might not be what's important to them. We're evoking the reasons why they feel like they want to make changes, which, for example, might be not the fact that they have asthma, but that they want to be able to run around with their grandchildren. Okay, so we're pulling out those values that are really important to patients. Yeah, did I miss anything?
That's great.
Great.
And so we'll continue to talk about this, but MI is really important in SBIRT, and this idea of partnership and acceptance, because a lot of times in SBIRT, it can be really hard to not engage in that writing reflex. So you have a patient coming in with risky substance use that might be directly related to all of these different crisis situations that they're continuing to come to you for. Your instinct might be to say, you have got to stop drinking, and, kind of tell them what they need to do, because you're concerned and you're worried, and you can see this bigger picture, like if you stop drinking, maybe these things would happen less. They probably know that already. We wouldn't be the first people to tell them, like, you got to back off. So instead, using this motivational interviewing spirit of acceptance and partnership and evocation helps us to stay away from that writing reflex and really engage with them in a journey of what's important to you and how are we going to get there.
And not only does that foster better rapport with our patients, but it's more evidence-based to lead toward behavior change than that confrontation writing reflex approach. Lots of evidence. Okay, so again, we'll return to motivational interviewing a bit later, but for now we're going to jump into the S of SBIRT, so the screening piece. I guess I'm curious first, how many of the folks in here, raise your hands if you are using some kind of screening tool for substance abuse or substance use in your setting? One?
Tell us more. What do you use?
Yeah, shout out some tools that you're using. The OSUB? Sure. Did you use the audit C too?
Yeah, I do.
Okay.
Audit.
I thought you did.
It's not at this job, but in my previous job, we used SBIRT.
Oh, sure. Okay. That's with kids, correct? Yeah. Okay. 21 and under, I should say.
Yeah, it was at
Okay. Great.
a bunch of us have worked in the ER, the audit.
Okay. Awesome. The full audit, the 10 items?
Yeah, I like.
Gotcha. Great. Any others that weren't mentioned already? Okay. Yeah, those are very common ones. Good tools. So some of those are shorter and some of those are longer than others. Like the audit, for example, is a 10 item, and we talked about the audit C that Ashley's using, and that's a 3 item. And actually, we'll show you an example of that in a slide or two. But We usually like to start with a pre-screening for these patients to just kind of identify if there's any kind of risk of use or risk of risky use, I should say.
Yeah.
Right off the bat.
Great. We do a single, quick, one-item question about each. So we'll do one item. SBIRT suggests that we use one item for drinking, one item for drug use, and this is how we can just start the conversation. So for me, a lot of my work I do is with depression society. So our equivalent would be like the PHQ-2. If a patient is positive on the PHQ-2, they get the full 9. So it's those little intro questions that help us figure out, is there more we need to explore? If the patient says no to both of these, we'll talk about what we do.
Right, absolutely. But yeah, the goal is to determine if there's a need for further assessment. And yeah, if they do say no to both of these, then I mean, reflect and affirm that, right? And then you don't need to go forward. Yep, actually. So this is an example of the audit C. So again, it's not a one-item question, but it's a 3-item question, and it's pretty good. It's validated, reliable, and it gives you a good sense of how often your patients are drinking, how much they're drinking in a sitting, and if they're a binge drinker, so the 6 or more drinks on one occasion. And the way this is scored is that, what is it? I'm trying to remember. It's 12. Right, and I was thinking risky drinking. So for women, 3 and up is positive for hazardous drinking or active alcohol use disorders, and for men, it's a 4 and up. So that might just be an indication that you want to have a conversation at that point. And for those of you that are at U of M, this is actually in my chart, and you can pull it into your notes if that's something that you wanted to use or assign it to patients during visits.
And probably who are at IHA, we also have it in our screen.
Great. Yep. And you can also find this on the SAMHSA website. I often would use it in a paper form with folks, maybe when they were in the waiting room. Sometimes it can be a time saver and can kind of get you out of that like expert role of like, you do this assessment and I'll have the answers. If you can have them do it in the waiting room before you talk, and then you can talk about it in a more collaborative manner, which we'll talk about. Yep. And this is just an example. Again, it's basically a spin on those 1-item questions called the NIDA modified assist. You can Google this. I actually have the website at the bottom, but it's hard to see. You can either do this in paper form, which they do provide a paper copy, or you can click through this on the computer when you're sitting with somebody, and it'll tell you which substances they're sort of at risk for when you answer these. Cheat sheet, if they say yes to any of them, they're basically at risk for it, so it spurs a longer screen at that point. So,
and after the training too, when we send along the slides, we'll send along lots of different resources, lots of screening tools, lots of longer assessment tools. So you'll get all of this good stuff in your email.
Yep. Great. So if the pre-screen is positive, like we said, you're going to administer a longer evaluation. This is not an exhaustive list by any means, but it's some of the common ones that you'll see used, and which some of you already mentioned. So we have the audit for alcohol use, which is 10 items. Doesn't take very long to go through it with a patient. And oftentimes it can feel really organic to ask these types of questions because it might be similar to what we're asking already in our biopsychosocials. The DAS is for drug use. It's 10 items. That one's pretty brief as well to go through, not too bad. The assist asks about all substance use, and it's sort of like tailored to how much you're using. So if somebody is a very heavy polysubstance user, that can actually be a really long tool to go through. But if they're using one thing lightly, it can be pretty quick. Again, the craft for patients under age 21 for drugs and alcohol, and then, I don't know how you say this, but QDIC, R. I actually wasn't familiar with this before this presentation, but it's apparently a reliable and valid cannabis use disorder identification test. So, yep. Again, these can all be found easily on Google. They're all available publicly. Okay.
Now we're going to watch a video to see how the screening happens. And the point of this video is to just show how easy screening can be, the really quick universal pre-screen, and then how easy it can be to start to administer the longer screen and have the conversation. We know how busy everyone is. We're not trying to give everyone this like wildly long intervention that takes an hour to complete because that's just not realistic. we're trying to give a shorter answer to this problem, or one possible answer.
Great. Let's hope the sound works.
Hi, how may I help you?
Hi, I'm Alex. I have an appointment with Dr. Winkle today.
Okay, let me check. Looks like you do have an appointment today, and you're due for your annual screening form. This is a form we give all of our patients once a year, and if you have any questions, please ask Dr. Winkle.
Okay.
The annual or brief screen is given to all adult primary care patients once per year. Patients who score positive qualify for a full screen.
Alex? Hi, my name is LaTanya. How are you doing?
Fine, thanks.
Good. I'll take the yellow folder, and I'll take you back to your room.
Okay.
Alex, if you could please have a seat on the exam table.
All right.
The medical assistant quickly scans the brief screen and gives a full screen to patients who score positive.
Here's an additional form for you to fill out. Please give it to Dr. Winkle when you finish.
Okay.
Thank you.
The full screen measures severity of substance use to indicate if a brief intervention or referral to treatment is needed. Hey, Alex.
How are you?
Good. Good to see you.
Good to see you.
So you're here today to follow up on the migraine, right?
Correct.
So in the last 6 weeks, how have those gone for you?
I'm still getting them.
As part of the visit, the primary care clinician addresses the full screen. So, Alex, we had you on a new medication plan for the migraine. Do you have any questions about it? Nope. Great. So before you leave here today, I saw that you took the time to fill out one of our alcohol screening forms.
Mhm.
Thanks for doing that.
Yeah.
Is it okay if I look at it with you?
Sure.
Okay, let's have a look. All right, here. So, answers on the full screen are totaled, and the category of use is circled at the bottom. Okay, so when I total your score based on your answers here, it looks like you scored into a zone of use we call risky.
Really? 'Cause I don't drink that much. Not a problem.
So your drinking doesn't seem like a problem to you.
No.
Well, I tell you what, if you're open to it, a colleague of mine here is great at talking with patients who typically score into this category to help them decide if they want to do anything about their drinking or not. That way, I'm just making sure I'm providing you with the best care we can. If it's okay with you, would you be open to me introducing him to you?
Sure.
Great. Well, I'll be back in a minute with Demo. Thanks. The primary care clinician performs a warm handoff to the behavioral health specialist. Alex, this is Demo. And Demo, Alex filled out one of the alcohol screening forms and said it was okay if we came in and talked about it with him. Is that okay with you?
That'd be fine.
Great. I'll give this to you. Thank you. And Alex, I'll see you next time.
All right.
Great. Thanks.
Alex, we haven't met before. I'm actually one of the healthcare professionals here at the clinic. Do you mind if we review the forms that you filled out?
No, that'd be fine.
Tell me a little bit about your drinking.
I just have a few drinks on Fridays.
And what do you?
The behavioral health specialist performs the brief intervention. Under the medical home model of primary care, the receptionist, medical assistant, primary care clinician, and behavioral health specialist all carry out the SBIRT clinic workflow.
Thoughts about that? What did you guys notice?
One thing I noticed is the doctor never specifically said, like, that my colleague ever said, I would bring a social worker in the room. And I don't want people to feel bamboozled, but also a lot of times what I find is that patients in clinic when the doctor chooses to bring me in, it's like a pretty fast eye roll. Or they're like, how are you today? And I'm like, well, not good. The doctor thinks you need to come in.
Right.
So I sort of appreciate, I would hate people to feel bamboozled by not being upfront about your role, but also I sort of appreciate there's just total like about that we're doing.
So maybe it actually felt like it was helpful in this situation, is what you're saying.
I think it was, but I'd be afraid to start sort of getting somebody into the feelings department and then being like, wait, who are you?
Right.
You're at a doctor's office, and I think that can be invasive, why it makes sense to be upfront.
Yeah.
But also, I don't know, but I think it's helpful, but I usually.
Yeah, absolutely. Pros and cons to the title, and like some people go by like behavioral health practitioner, and they might not know what that routines, which again could be good or not good. Yeah. Yeah. What else do people notice? Could be something that might fit into your workflows in your clinic, you know, maybe something a little more realistic than this, but.
So a lot of times we don't have the study, like the actual study space to have that conversation. Okay. We do have an office that we often told, like, can you go there? Sure. But, you know, I work in a primary care pediatric center in Teague. Okay. Their appointments are 15 to 30. Yeah. And so there's a lot of clinic flow. They wouldn't just like be in there. Yes, if you're fine. Like, ask all your questions.
Sure, you'd have to move.
Yeah.
Okay.
Yeah, there was no.
Yeah, if there was. Okay.
Yeah, if there is.
Good point. So how long do you end up having a patient in the room? typically?
It varies by provider and by the day. Some actually do say like stay and some are like, and you have 2 minutes and then the MA is going to knock on the door. And if you don't have a room, then you.
Right, sure, so. Yeah, 2 minutes to fix everything.
Yeah.
Got it. Got it, yep, absolutely. I think that's a good point, that we all have different competing demands, different settings. So again, sometimes it ties it up with a neat little bow when we're watching videos like this, but this can be tailored to make it brief. These types of things can be followed up with on the phone as well. Like there's no thing that has to be in the clinic room in a setting with the doctor. Yeah. Good point.
How successful or how does that affect you? When you're doing that follow-up by phone?
So
That's one of the issues, but actually.
Right there, yeah, that's a good question. I would have to check the research on it, but I mean, we do know that other brief interventions can be affected by phone that are MI based. So my gut tells me it would probably be pretty darn effective, and we know that the research even backs it up enough where we're billing for some of these phone-based services now. So good question, but I know that I can speak from the collaborative care setting that we did a lot of screening by phone, and that felt natural enough. It was pretty doable. We would ask patients permission, and they would typically be fine with it. We can also screen via the portal if patients are amenable to that. And then, yeah, if we can deliver the brief intervention by phone, then that's just fine. Certainly do MI that way. Yeah. Hi.
So that they don't feel like they're targeted.
Right.
Absolutely. Because the way SBIRT is designed, really everyone should be getting it. Even if they've never had anything about alcohol in their chart, everyone should get this pre-screen once a year.
Yeah. Which we know in our sites can be a hot topic. Like sometimes clinics are hesitant to do universal screening, and that just generally is a hot button issue, because what do we do with this when we have this information, when we've uncovered these issues? But we do know that the majority of folks that are screened are falling into that like low risk to moderate risk category. So we're not typically uncovering tons and tons of severe like substance use disorders. It's more folks that we're doing sort of brief intervention preventative work with. So one other thing I noticed from here is that there was just a lot of asking permission, like would it be okay if we went through this together? Would you mind filling this out? Would it be okay if I brought in my colleague? So it felt decently collaborative in that sense. Yeah.
Always promoting that autonomy.
Mm-hmm.
Yeah.
Like with lower literacy levels.
Sure. Yeah. Okay. Great.
We
What
could.
do you think? Yeah, we could, an MA perhaps,
Yeah.
when the patient is being roomed.
Mm-hmm.
I know that, so I work in primary care, in terms of Arbor literacy folks. If I ask the MA to get a PQ, they'll just ask the patient the questions verbally.
Mm-hmm. Yeah.
Very much a team-based,
Yeah.
have all players on board.
Right. Just as effective to do it verbally as it is to do it on paper.
Good question.
Yep. All right. So for some reason, there we go. So since we're talking about screening and identifying substance use disorders, we just wanted to spend a brief moment just kind of talking about the DSM-5 substance use disorders. Kind of felt like it naturally fit in here. So you all might be familiar with this, maybe not, because it is kind of newer. So So we're just going to talk about the main kind of differences between the DSM-4 and 5. One key point is that we're no longer specifying substance abuse versus dependence. So disregard that language on our earlier slide where that was still DSM-4 based from SBIRT. SBIRT's a little older. So everything is now a substance use disorder, and we're specifying the severity, whether that's mild, moderate, or severe. We can also, if patients are in remission, we can specify early versus sustained remission. Early remission is between 3 and 12 months. Sustained remission is 12 months and beyond. We can also specify whether they're on maintenance therapy, medication, MAT, medication-assisted treatment, or whether they're in a controlled environment right now, like an inpatient setting where they don't have substances accessible to them. The most common, what am I trying to say? The most common diagnosed substance use disorders are those listed here: alcohol, tobacco, opioids, cannabis, stimulants, and hallucinogens. And when we're diagnosing, we do specify each substance separately as a separate use disorder. So when we're writing that out in the chart or making that diagnosis, it's a cannabis use disorder, alcohol use disorder, and we're even including the specific substance. So for example, moderate alprazolam Xanax use disorder. Questions about that? Just a quick overview. And then in terms of the criteria, so this has changed a little bit too. In the DSM-4, you had to have just one to qualify for a substance use disorder. But now you can see that of these 11 criteria, you have 2 to 3, you'll be considered mild, 4 to 5 moderate, 6 plus severe. So the criteria are still very similar. So taking more than intended, trying to cut back to having a hard time, different cravings and urges to use. Maybe you're not meeting your obligations or fulfilling like your family or work or social responsibilities. You're using even when it's dangerous to you, developing a tolerance, or you have withdrawal when you do try to stop, so, amongst other things. Okay. Any questions about screening before we move on to the brief intervention? We don't spend a ton of time on it because it's pretty straightforward. We all are capable of screening our patients. So, okay, the key will be probably just accessing those screens online and looking for those resources that we send as follow-up in case you guys want to try using these, or even looking through your EMR to see if there's any available that you might want to use.
So thinking about the brief intervention piece, which is really the bulk of what we're going to focus on today. So what happens when that screen is positive and the longer screen is positive? What are we doing next? So brief interventions are time limited. So it can be 1 5-minute conversation. That is like the minimum of what we would say is brief intervention through SBIRT, all the way up to 5 or so brief sessions. So these aren't hour-long therapy sessions. These are brief 10 to 15-minute follow-up sessions. And this brief intervention, we target a specific health behavior. So things like reducing smoking, reducing substance use, stopping alcohol use. And the point of these brief interventions is to help patients increase their insight and awareness around their substance use and also enhance their motivation for change. So when we do that more extended screening, we utilize the information that we learn in the intervention.
Yep, absolutely. And I think it's important to note that, well, we might note this later. Yeah. Hold that. We're going to note it in a second. Okay, but we do know that brief interventions have an evidence base in a lot of different settings, whether that be primary care, emergency departments, like senior housing, college campuses, CAPS, like they can work in a lot of these different places that we already named already. Great. So what are we hoping to achieve with brief intervention? So we want to kind of assess the patient's readiness for change. So kind of understand where they're at in terms of their perspective on their substance use. Do they have any concerns about that? Have they been kind of thinking about making changes? Are they already taking steps? Have they tried to in the past? And when we talk about readiness for change, that comes with a lot of different components. That's us asking about, like, how important is it for patients to make this change? How able do they feel to do this? And, how can we be helpful in, increasing that sense of ability to do this? And as well as how confident are they that they could walk out of here and actually make changes in their life, that they decided that that's the right choice for them. We also want to learn about patients' resources and level of need. So we want to understand kind of where they're at in terms of their severity, how urgent this is to them, and objectively maybe how urgent this is, and be able to feed that information back to the medical team if appropriate. And we want to learn about their resources in terms of, I think we're really talking about two different kinds of resources. So external, so like, can you get to where you need to be to support your success in terms of like transportation, if you're going to treatment, et cetera. You have the finances to cover it, the insurance coverage, but also internal resources. So what kind of strengths do patients have that they can bring to the table that can help them to be successful in making decisions that they would like to make? We also want to offer education regarding how behavior and current risks could impact their health. So we use the term offer intentionally, not give, because we're asking patients if they're interested in learning more. Like Teague mentioned earlier, when somebody is drinking or smoking or using their pain medication not as prescribed, like they've often heard these spiels before, and often it's the first thing that they hear when they go into a medical appointment. So taking that stance of sort of the confrontation and the lecturing usually isn't going to be helpful. So asking patients if they'd like to learn more after we've already engaged and partnered with them, and oftentimes they do. I mean, we're the experts in some ways, and that we've received certain levels of training in our fields, et cetera, whereas they're the experts in their life, so we can kind of, share what we each have. They would like to talk about it. As well as promoting positive behavior change with the goal of reducing risky substance use. So we say reducing risky substance use. One thing to note here is that SBIRT can work for folks that come from kind of all belief backgrounds, whether that be abstinence only or harm reduction. And it depends if patients are referred to treatment. It depends on the facility and how they're going to treat patients, but this can kind of work for anywhere along the spectrum and where you come from and where the patient's coming from.
So we know that brief interventions are brief, but they work. We don't spend a ton of time touching on this, but this is a hugely evidence-based model. The research shows it works. The research shows that brief interventions are low cost, they are highly effective, and they stick. So the impact that we make doesn't just last for a few minutes after we walk out of the clinic. They've shown reductions in at least 12 months moving forward, and a nice amount of patients, between 10 and 30% be expected to be service years with these interventions. And we do want to note that SBIRT is most effective for patients with less severe issues. So if you have someone coming in, excuse me. So if you have a patient coming in who is in a severe crisis situation, these brief interventions might not be the best fit at that point in time.
Yeah, exactly. So folks that are more along a severe substance disorder might warrant a higher level of care, which we'll talk about. And to speak about like the brief and the last thing, so that's what I did when I worked in the emergency department, is we would do typically on average like 20 to 40 minute interventions that were MI based, talked about strengths, gave feedback about their alcohol use, and would kind of, if they were willing, talk about a plan moving forward. And like so many randomized controlled trials show, like that sticks. You spend this like brief amount of time with patients for 20 minutes of their life, and for a year later, they could still be making changes. It's pretty fascinating. It's just about what we're kind of pulling out and what we're connecting in terms of patients' goals and their current behavior, and something about it just really works. Go ahead. Yeah, certainly. So I guess we could probably talk about that a little more when we talk about MI, but good point. Like that patient support system can be a huge piece of this if that's something that feels right to them. So, as you know, generally we're going to give the patient the option to have somebody in the room while we're doing these interventions. But usually part of doing a brief intervention is talking about strategies for making a change, and we'll elicit that from patients and find out what they've done in the past that works well for them. And those types of things might come out, like, oh yeah, when I, talk to my partner when I'm having a craving for a cigarette instead of going outside, then that can really help me. So, asking permission to maybe bring the partner into the room and involving them in the care plan could certainly make sense. Yeah, but again, all it's up to the patient and what they think is going to work for them. Great. Any questions about that?
So the key components of the brief intervention are listed here. And on the white handout is kind of a list of these. And then this yellow card we'll talk about in a minute. So we start by screening and assessing. Check, we've already done that if you're at the brief intervention point. You raise the subject, and we'll go into detail on all of these. You raise the subject, talk about pros and cons of use, and then at that point, providing the feedback of this is where you fall on the chart, and then eliciting motivation for change. After you've started to pull out that change talk, those reasons why maybe they want to cut back, then you start brainstorming strategies for change. You set some concrete goals, and then if you have time, like if it's realistic in your situation, you plan for a follow-up either in person or by phone. Yeah. And so you'll see, we're going to show you a video next of what the brief intervention piece looks like. They use this yellow card, and a lot of folks who do SBIRT use this, which has got a lot of good information right there that you can pull out and show the patient. So it's got this categories of risk, it has our drinking limits, and then it has a ruler, which we'll talk about too. And one thing we wanted to note too with this chart, it's not 14 drinks per week or 4 drinks per day. So you can't have 4 drinks every day as a man, because that's 4 to 7 is 28. That's more than 14. So no more than 4 drinks per day or 14 per week.
And.
Yeah.
So you could have 2 a day, or you could have, 4 3 times a day, or you know what I mean. Whatever, you get it. But anyways, that still leaves people in the low risk category. And, SAMHSA is very clear to say, like, yes, you're low risk, that could still come with risks, FYI, if you're having 4 drinks in the sitting. Particularly important to think about age. Hence, you can see here that for both men and women over 65, it's less. You want to think about what medications people are on, whether they have any medical conditions, what their job responsibilities are, you can go on and on. So
this is a nice starting point for the conversation, but
is that surprising to anybody, these drinking limits or new information? You guys might be familiar with it.
This is fine with me, but I have a question because years ago, what my attendings on my team would say to me is, whatever they tell you, double it.
Crystal said, yeah.
You still do that?
I think that personally, that doesn't fit into my sort of belief system of working within like a motivational interviewing framework where, we are accepting the patient, creating this positive regard, and like trying to engage with them and think of them as the expert in their life. They may or may not be telling us the truth, but we can still move forward and engage with them and see where it takes us. We might find out more as the conversation goes forward. So I don't think that if somebody told me they were drinking 7 drinks a week, I wouldn't document in the chart they were drinking 14. You know what I mean? Yeah, just patient states. Yeah.
And I think with this approach, that makes sense to me because I think this approach, you're building this rapport right to start, so that people aren't so defensive about, tell me how much you drink.
Yeah, exactly.
I think it gives a chance for them to feel a little more comfortable about sharing.
Yeah, that's a great point.
That's why I asked. I thought, I'm not sure that I would think that.
Yeah.
We have an old school viewpoint of the patient. Oh, they're not really going to communicate clearly with me. I know better, and I know.
Yeah.
Other things that are kind of become more acceptable now. Talk about all of these things, and people feel less afraid of their doctor as in this position of power.
Yeah.
Collaborative.
That's a great point.
And the nice thing about this too is that it's a mutual process back and forth throughout. So like we raise the subject, we talk about pros and cons, by asking a patient what's good for you about your drinking, they're seeing it. We're not coming up and saying, oh my gosh, you need to start drinking less. It's really facilitating a good conversation. And then as you move forward if a patient wasn't being completely honest. There are other opportunities. I've had folks say, well, actually, I guess if I'm being honest with myself, I am drinking a little more than I said, because we've kind of opened up and started to build that rapport. So I think that brings up a great point.
Yeah, that we're not so much in their expert role anymore. Like you indicated. Yep. And yeah, just to drive home that like most people are in the low risk or abstaining category. That's pretty common, so that's helpful to keep in mind. All right. Sounds good. So oh, sure. So typically, so men and women, so on average, the reason stated is that like men tend to weigh more than women on average. Obviously that varies across the spectrum, but also they metabolize alcohol differently. So I know it's a pretty drastic difference. And I think that I was actually surprised back when I first learned these guidelines that men could have 2 drinks a day and still be in that low risk category.
4 drinks.
Well, not every day. Yeah, so all about how they metabolize it, size, et cetera, lots of different factors. But this is just sort of like a general average with the caveat that we should always be looking at people individually. Go ahead. In terms of the drinking limit, I'm not sure about that, Wendy. I have to look into it. I admit my work has all been with adults, so I'm not as savvy with that, but
I'm not sure, but I'm going to look into that because I'd be very curious to see what this yellow card would look like if I was. And they have there's a great website about SBIRT developed out of the state of Oregon from a grant that they received. They have adolescent information on there, so maybe during the break I'll pull that up and I'll see what they say.
Yeah. Another question? Well, hi, Amy.
I'm just wondering, like, when you're working with transgenders, how that tool can maybe be very offensive.
Yeah.
Or are there other types of ways they show the range without maybe specifying gender?
That is such a good question. In this, like, SBIRT is a little bit outdated in some senses, as are like every website from NIAAA and like NIH when they talk about these things, they just look archaic. So I feel like, yeah, like where we're at nowadays doesn't always reflect on these.
Yeah, and I would say this yellow card, you don't have to use it, you don't have to show it, it can be a guide for you, but definitely if I was working with a transgender patient, I wouldn't say, well, which category, that's so like not what social work is all about.
Yeah.
That raises a great point.
Yeah. I don't know, how would you guys approach it? Or we have another.
Well, the way I approach it is, rather than looking at hard set numbers, and is talking about the relationship.
Yeah.
Because they may, I have had couple of who really have pretty mild views, very mild categories, but their relationship with me really risky.
Exactly.
And that's what we talked about.
Yeah.
And that also, talking about it in that way also ends up being a side door in working with them so that they aren't so defensive, realize it's okay to talk about. And I'm not saying that they're they were much more ready to say, well, yeah, I do have this relationship with my friend.
Yeah.
Vodka or whatever it is.
Absolutely. I agree with you that sometimes providing kind of feedback can be a little bit awkward, to be frank. There's a way to do it that doesn't feel super awkward, but you don't always have to, I know what you mean. You can talk more organically about like, well, tell me what your alcohol use looks like and kind of, what does that do for you?
And I think that speaks to the nature of social work and the training that we've received and the flexibility that we have to have. So if if a patient is drinking 15 drinks a week or 13 drinks a week, I think that's going to be pretty similar to if they're drinking 14 drinks a week. So it's really about, assessing not just how much, but their relationship and where they're at in that process.
Yeah.
Thank you.
A side note, but I think questions for like older adults, they don't, when you like talk about the they don't realize how much they can metabolize increases as they age, and if they're on like a lot of medication, people can have
glad you brought that up because a lot of our materials, focus on alcohol just because it's kind of what's available on the website, but so many other things are important, especially with older adults when it comes to like prescription drug misuse, being on benzodiazepines, things like that, where they're not aware that it can increase their fall risk or risk of motor vehicle accidents, and providing that information in the way that we're going to be talking about, like, can certainly be really helpful with that population too. Yeah, good point. Great. Okay.
So let's see how it's done.
This is Jill. We'll be spending about 5 minutes with her.
Jill is a 54-year-old female who is being seen for a follow-up visit related to her hypertension. She also presented 6 months ago with a fractured arm from a fall on her steps. During this visit, Jill scored in zone 3 on the audit, the harmful category.
So Jill, I know you're here to talk about your blood pressure today. Before we get into that, I see you filled out our annual screening forms here. So if you're okay, can we take a minute to talk about that?
Sure.
Okay, great. It looks like the way you filled out the alcohol form puts you into our third zone of drinking. Can you tell me a little bit about your drinking habits? Where you drink? Where do you like to drink?
I drink wine.
Okay.
I go down to the little pubs down the street.
Mm-hmm.
Have a few glasses.
Okay. Kind of socializing.
Mm-hmm.
All right. How often do you do that?
3 or 4 times a week, probably.
Okay. And on a regular night, how many glasses of wine would you guess you drink?
3 or 4, 5.
Mm-hmm.
Maybe on a weekend, maybe 6.
Okay.
Over a period of time.
Mm-hmm. So let me just show you on this card here. From a medical perspective, we know that there's good evidence that shows that women your age who drink more than 3 drinks on any one occasion, at any sitting, or more than 7 in a week, are likely to run into health problems when they're drinking, either problems they're having right now or maybe in the future.
Are you serious?
Yeah, surprisingly.
7 drinks in a week doesn't seem like that much.
Sounds like you're drinking a bit more than that right now.
Yeah, I didn't think it was much, but that makes it look like I'm drinking way.
From this drinker's pyramid over on this side of the card, you can see that the score on your screening sheet shows that you're up in the harmful category of drinkers. So that it's likely you're drinking, in quantities, probably more than about 90% of the folks who come in to see me here at the clinic.
Well, I know my drinking has increased a little since I got divorced and moved to Portland, but I don't think it's that much of a problem.
Doesn't feel like a problem to you right now.
No, not really.
Yeah. Okay. And then the other thing I should mention, Jill, drinking more than these quantities, it's possible it could be pushing your blood pressure up a bit. And I'm wondering if that might be affecting the difficulty we're having getting your blood pressure down right now.
I didn't realize that drinking had anything to do with blood pressure.
Yeah, it can sometimes.
Oh, well then, I guess that could be a problem.
My perspective as a doctor, it would be good if you could think about cutting back a little bit or doing something different about the drink. What do you think about that?
I guess I could cut down.
So on a scale of 0 to 10, 0 being not ready at all to do that and 10 being very ready, where would you lie on that scale?
It's probably a 6.
Okay. So I think that's great. So why would you be up at a 6 and not down at a 2 level? What kinds of things would push you to be up there?
Well, I didn't realize that drinking was related to my blood pressure problem.
Yeah.
And I did fall earlier this year on my way home from the bar and hurt my shoulder. I don't think the drinking made me fall, but it probably didn't help the situation. And my son keeps telling me that I'm drinking too much. It's scary to think that I'm drinking. The big word.
Yeah. So you've got some good reasons to try to cut back a little bit. Yeah. And it sounds like you're willing to maybe try not going to the bar quite as much and maybe drinking a little bit less when you go to the bar.
I think I could try to do that.
Okay. So to what levels do you think you could do it? Where would you want to go with your drink?
I guess I could use those numbers and can't make any promises, but I could try to drink less than 3 in a night and less than 7 in a week.
Okay.
I mean, I could only drink 2 or 3 times a week.
Mm-hmm. So you would drink maybe just a couple times a week and maybe a little bit less on each occasion? Is that what you're saying?
I could try that. Yeah. I don't think I need to quit, but I think I could try that.
And you think you're able to cut down to those levels of no more than 7 a week?
Well,
Okay, I think that's a great step forward as your doctor. Why don't we revisit this the next time you come in to talk about your blood pressure in about 6 weeks or so, and we can see how you're doing with it.
okay.
All
Sounds
right.
good.
Well, let's get back to your blood pressure then and see what we need to do about that.
Okay.
All right. So I think, caveat, no video is perfect. I think there are some things I noticed that went well and some things that maybe Teague and I would do a little bit differently, which we'll elaborate on. But what are your thoughts? What did you notice that felt maybe, first of all, like helpful within this interaction? Go ahead. Mm-hmm. Sure. Yep. Yes, good point. And it didn't seem to really lecture her too much. Yeah.
So. Yep. Seems good that it just really. It's like for blood pressure. My that's so well. Great. I heard identify the subtle. But what is great? What is
Yeah, it gets her arguing why it's important to be making that change.
Yeah.
For sure.
We'll talk more about lower in a bit, but it's always great to start lower and ask, why not push for 3? That's going to bring up that.
Yeah. Sure. She came in for that issue, so clearly it's important to her at some level. So tying that in is helpful. Good question.
Well, I like the way you just, okay with that. Just
Good point.
I think that's really important. To feel like you got to keep things moving along.
Yeah.
And I appreciate it.
Absolutely. Sometimes we're crunched for time, so we feel like we have to get in as much information as we can, but ironically, that can be less efficient at times.
I appreciated how on the one medical issue and that you tackle it all in other ways.
Sure, good point.
It's really what you
It's a great point. Yeah, you're really hurting your liver.
Yeah.
Right.
It's
Yeah.
all about that, like, we know a lot of things, and so it's like, what are we going to share to help move this forward, and it's important.
Yeah. Anything else? What did you have? Okay. What might have you done differently? Anything stand out or tweak?
Well, refer to this as a drinker experiment.
Yeah. To be, like we talked about, SBIRT is a little old. Some of these videos are a little older. I would love to, like, remake my own.
Yes.
Yeah.
With you on that one.
Good point. And it's those little subtle things that are important for us. So,
Yeah.
So, I kind of have an issue too, because people, they can drink 2 drinks.
Yeah.
You are very correct.
Thank you for bringing that up.
Yep.
Yep.
So we're going to talk a bit about a standard drink and how to incorporate that conversation. Yeah. A drink for me might look different than what is a standard drink, especially with the craft beer. Yeah.
Yeah. I think good point about the pints. Like that would come out sometimes with patients in primary care. Like that's a drink.
Yeah, or like a Long Island. I have 2 of those a night.
Yeah.
That's 2 drinks.
Right. Anything else that came to mind? One thing. Oh, go ahead, Wendy.
difficulty with why there's that. Social workers don't do that, but
yeah, exactly. And that's a good point. I guess we can touch on that when we talk more about motivational interviewing, but we kind of equate these types of brief interventions to like an aerial perspective. So like imagine that you're overhead and you're looking at a map and you're just sort of trying to understand all of the different directions that you could go with the patient and like the things you could talk about, and you're just sort of gathering information, and we don't want to dive in too soon. We just kind of want to get this kind of menu of things that are important, and then later on in the brief intervention can kind of go in and kind of decide which path to go down. But you're right, it's tempting. We hear things and want to go down that road. I also noticed when he was talking to her, he used what we call like qualifying language or undershooting, which is kind of like a softer language that can help people to keep their barriers down a little bit. So, you know, part of you thinks like, or maybe you just want to decrease a little bit when you go out. Just those little tweaks in language can be really big. And we do actually know that when we kind of undershoot and pull back and say a little bit, just some, maybe, that patients are more likely to argue in the other direction. Whereas if we overshoot and say, you're ready to quit right now, people might be like, oh, I don't know about that. Yeah. And that's just natural human behavior. When we argue one side, they want to argue the other, and that's how debates work, et cetera. So if we undershoot, that tends to serve us pretty well. Yep. Great.
So let's dive into how to address all of the components of the brief intervention. So we start, after we do the pre-screen and then the screen, we start by requesting permission. So saying something like, thank you for filling out that paperwork. Is it okay if we talk about it? Because this is a conversation. It's not a lecture. And so continuing to ask permission helps foster that spirit. And then we move into going over their survey or questionnaire results. So I see here that you said you have 3 to 4 drinks about 4 nights a week. Is that right? Mm-hmm. Can you tell me a little more about that? If you want to get really fancy, you can say something like, how does that fit into the rest of your day? So just really being open a bit to understand, like Sarah said, pulling back, taking that bird's eye view and really just observing what's going on.
Yes, absolutely. Doing the assessments can be kind of an interesting thing too. I touched on this a little bit, but when we go into these like standardized questionnaires, sometimes it can kind of implicitly place us into that expert role. Like, you fill out all of these questions and tell me everything that you're doing, and I'm going to have the answers for you. But that's not true. Like, you know, we might have some ideas, but we don't have all the answers. We're not the expert in their life. So really framing the assessment in like a really collaborative kind of, you know, have yourself on the same level sort of way can be really helpful. So, you know, even asking permission before they do it, like, would it be okay if we had you fill this out? And then after they do it, like, you know, so you spent 5 minutes doing those questions, like, what are your thoughts after going through that? Like, you know, what's on your mind? What really stood out to you while you're doing that? And that can kind of just show that you're curious about, you know, where they're coming from. So another thing to try out. Great. So we've kind of touched on this, but if a client isn't ready, if the patient isn't ready to discuss their use, avoid confrontation and respect their decision, and just let them know you're open to discuss it further if and when they're ready further down the line. So if they don't want to talk about it, then they probably aren't ready to make changes. You know, it's just forcing the subject isn't going to get them to cut back on their substance use. So, you know, continue to engage with the patient. When we're talking motivational interviewing, like, engaging is the foundation of everything that we do. We know that as social workers as well. So continue to engage, continue to engage, and learn more about their use if they're willing to talk about it, and maybe you'll have an opening later down the line. I know that I've been just, I'm sure some of you have too, but fascinated when we don't come in with that confrontational approach to our patients, when that's maybe all they've been receiving from their other providers. Like, it's like you see their shoulders relax sometimes, and like, you know, I've heard things like, I've never been able to talk about this with anybody because every time they talk about it, it's like, well, you need to stop. You can't be smoking pot while you're pregnant. But if we're actually willing to kind of go in that dance and have that conversation, we might learn so much more. And maybe they'll be willing to talk about changes later down the line.
So next step of the brief intervention is just in a very open conversational way, talking about the pros and cons of use. Just saying something like, can you help me understand a little more about your drinking and how it's fitting into your life? So what are some of the benefits of drinking? And patients might be shocked to hear that question, like a medical professional is asking them what the benefits to their substance use are. And what are some of the drawbacks? So really just that non-confrontational, non-judgmental, open conversation. And so after you've had a bit of more of a conversation, learn some more, you make a summary. So on the one hand, you like drinking because you go to the bar with friends and you socialize, and your anxiety that you feel all the time is minimized after a few drinks. And on the other hand, in the morning you wake up not feeling so great, and you also wish that there was a different way maybe for you to work on your anxiety. Do I have that right? Continuing that.
Yep. I think this is a good way to learn about what people's values are as well. Like, if we ask them like, what are the good things about your benzo use? Well, it really helps me relax enough where I can like get my kid outside and I can actually like leave my house and take them to the park. Your family is really important to you. We start to pull out these values, and while we're talking about, the benefits of their substance use, we're learning so much more about them and like ultimately why they're doing the thing that they're doing oftentimes. That makes sense.
Yeah, think of that.
Yeah. Is this something that you guys are practicing? Anybody? Yeah. Great. Providing feedback, what can often be the awkward part. So you'll notice that in the last slide, we kind of just approached this from an open perspective already. So we're trying to understand, like, what are the pros of drinking? What are some not so good things that might come up for drinking from you or for you? Tell me what you know about drinking. We might even ask them that. Just try to learn, they probably have a lot of information already, so trying to pull out what they already have on hand, or summarizing that. And now after we've already kind of done that and pulled out what they know, oftentimes we're going to provide a little bit of feedback. Whether or not we use the card can vary, but we might also just be providing general feedback about, how alcohol use might play into the medical condition that they're here for, or how benzo use can affect them as an older adult, things like that. So one key thing that we want to do when we're providing feedback is asking permission. So I have a little bit of information about how benzo use can look in older adults and what kinds of effects it can have on people's health. Would it be okay if I shared that with you? It can feel super awkward sometimes to say something like that and scripted. I promise you it's not as awkward as you think. And asking people permission supports their autonomy and helps them feel like they have a say in how this conversation is going. You can also do it a little bit more fluid. Like, I have something I'd like to run by you, if that's okay. Just find something that works for you in terms of your language. It doesn't have to feel like a robot. So then we'll give the information. So, here's the example using that card, but again, we're talking about all different types of substance use. So, we might give the information about what we know about marijuana and depression and what that can play into or whatever. It just depends on the patient that we're working with. So after we give that information, and one point with that is we want to give information that feels relevant to them. So it was good that you guys brought that up. He didn't give the whole gamut of what alcohol can do to your health. He focused on what's important to her. She has high blood pressure. It was. So how does alcohol play into that? So don't make it too long. You don't want to make too long of a summary, too much information, because people will zone out. It's hard to absorb all that information. Keep it fairly brief, and then ask what their thoughts are. So after you've given that, so given what we just talked about, what do you think? Where does that leave you? How does that make you feel? So it's sort of this like dance again, right? We're not wrestling, we don't have them in a headlock, we're not trying to force them to make a change. We're getting their information first about what they know, asking if we can give information, and then saying, well, what are your thoughts? You know, showing that they have the autonomy to accept that information or just leave it by the wayside and move forward with their life. Questions? You'll hear this called elicit provided elicit. We'll talk a little bit about later too.
And like Sara talked about, when it's time to provide the feedback, come with the facts. It helps to know the facts. So knowing about medication interactions, like Sara mentioned, how youth can interact with a medical or a behavioral health condition, as well as the impact of substance use on things that affect the patient and some of their different characteristics, like pregnancy, age, driving safety, family, work, all that good stuff.
I think working in medical settings as social workers, we learn so much about like the conditions and the medications and things like that. So typically we're often prepared with these things, but particularly in places like primary care, I think where you can like see everything, like it can be a little overwhelming, but the more we know, the more that can be helpful in these.
So standard drinks. These cards are very helpful. We don't need to go into it in great detail, but this 12-ounce beer is a 5% beer, so not a lot of craft beer fits into that. A shot and a half of a spirit is a drink, so like a Long Island is more than a shot and a half. Yeah. So you get the point. Yeah, and using that when you're talking to patients about a standard drink, because they might say, only 5 ounces of wine, my glass is filled all the way to the top, and that's what I consider a drink, helping to provide a bit of that. Right.
Or I had 2 craft beers, so that's actually 4 drinks. Yeah, no. Especially nowadays, that's pretty common. Okay. So brief intervention, elicit motivation for change. On to our next step. So we want to find out how the patient is feeling so far. We asked what their thoughts were about the information that we gave, and now we call this kind of like the key question. So given everything we've discussed so far, we've talked about like, you know, that marijuana use like really has these benefits for you where, you know, you feel like it kind of helps you get out of the house and makes you feel a little bit anxious. And at the same time, like your wife is really on you about this and it's feeling like a major hassle. We kind of talked about how it maybe could be playing into your depression at this point based on what, you know, some of the research shows us. So I'm just kind of curious, like given everything that we've discussed, where do you see yourself going from here? So it's just a summary. So we this can be a turning point for the conversation where hopefully we've engaged with the patient so far. Hopefully we found a focus, which is like, you know, talking about that particular substance use or medical condition. And now it's totally up to them. It's that dance again. We're turning it back over to say, it's totally up to you. We can stop talking about this right now, or we can decide to maybe think about making some changes and, you know, go from there and talk about it. Pretty straightforward, but it can have pretty significant effects on the conversation to ask patients like this. So utilize motivational interviewing skills, ask open questions, respond reflectively and strategically when people are sharing desires, reasons, needs, or steps they've taken around change. We want to be really in tune to patients giving us that kind of change talk and really responding to it and not letting it fall flat and kind of looking at it as an opportunity to, you know, continue to build motivation. And our goal in MI is also to develop discrepancies between current behaviors and future goals. So we may have learned a lot about what's important to folks. For example, when we asked about like the pros of their use, we might have learned about their values, or maybe we even just straight up asked them in the beginning, like, what's important to you in life? Like, what really, you know, what keeps you here? You know, what gets you through your day? And so if we're kind of mentally cataloging those types of things, then we can try to develop discrepancies where maybe patients' current behaviors aren't really supporting them to, you know, attain or maintain those things that they really value. Okay.
Next is some of the fun parts. So brainstorming strategies for change. First and foremost, we want to start by asking the patient what they already know or even what they've already tried. Like we've continually talked about, patients usually know that their use of their substances isn't great, isn't optimal, and maybe they've even tried to cut back or stop altogether. So you mentioned you quit smoking in the past, or you mentioned you've tried to quit smoking So learning more about what that patient has already tried. And then asking them, what else? What else do you think you could try? What have you heard of? What have you considered doing? And then if you're kind of running short on ideas, or if you feel like there is something that the patient doesn't know that might be worth them knowing, you can request permission to give them more information. So if it's okay with you, I'd like to share a couple other strategies that some of my patients have had success with. Is it okay if I share those? Yeah. The nice part about starting with what the patient already knows is that you're not repeating what they already know. You are learning more, and so they're not going to be sitting there starting to zone out like, okay, she told me to try the patch. I've already tried the patch, it didn't work. We're getting more information, so our time can be more efficient. And then also at this point, troubleshooting some of the barriers that they foresee and talking about how to overcome those around them.
Yeah, absolutely. I think that this is also an opportunity to like affirm our patient's strengths. Like, you have been successful with this in the past. Like, it's not easy to quit smoking, and yet you were able to do it for 3 whole weeks, you know, and just really like any kind of change talk or like strength, like from this perspective, we just want to affirm, like rather than, oh, you only quit for 3 weeks. Well, you need to quit for a lifetime. Like we want to flip it and go at it from the other way.
Yeah.
Obviously, I think from a social work perspective, but not obvious to every provider. Yeah. Are there any other ways that people in this room kind of talk to their patients about eliciting like strategies for change or talking about, you know, next steps that we maybe didn't touch on here yet?
Like to in part acknowledge that it's fairly change, right? Don't stop drinking and keep your breath and you're good. The one thing that you do, what 5 things are you going to do that are going to add up? People here, okay, stop drinking instead of what else?
Yeah, great point.
Yeah.
Having a diverse plan is kind of a menu of options to choose from, or like a toolbox, whatever you want to use, to be really supportive. Great. So maybe like, you know, working with patients to come up with tons of different strategies, and even if you can like jot those down on paper when you're done, that can be really helpful. And I feel like that kind of gets at troubleshooting barriers too. Like, you know, it's not going to be all sunshine and roses when you start deep breathing. Things are still going to be difficult, and life happens. You walk out of this room and you have like friends coming at you and offering you things, or you're lonely and you really just want to go to the bar and see your friends. That's where your social circle is. So what's that going to look like? You know, what might be a challenge for you? What could make it difficult for you to not walk down the street to the pub? How might you navigate those? How have you done it in the past? And it's like we can have ideas and we can offer those with permission, but they're the ones that know their life, so they're going to come up with the best ideas for how to navigate these barriers. And I think that was one thing that kind of gave me a gut reaction in that video, was he jumped really quick to planning and was like, okay, you're going to quit drinking.
Yeah. Or like, you're going to only go to the pub twice a week.
Yes.
You're going to go to the pub and have a Coke.
Yeah, exactly.
So really learning more what they do.
Yeah. Right. She's going from drinking like 5 to 6 drinks in a sitting to 2. Like, that's a huge change. Yeah. So what might make that difficult? Let's be realistic. Yeah. Any questions or thoughts about this?
The fun part. So helping the patient to develop a plan. And like we talked about in Arbor, with the time constraints and just the way life works, sometimes we don't get to this point where we get to make this beautiful, like wonderful plan of you're only going to go to the pub 2 times a week and have 2 drinks, then great, done. But if we can get to somewhat of a plan, great. And plans are helpful when they are using those SMART goals. So measurable, actionable, and measurable, things like that. And so asking and opening this conversation with what might be your first step? How might you start with it? What if you are going to start smoking a little less marijuana? What's your first step? And then, if necessary, offering ideas and recommendations. Always knowing that it's the first step. But usually people are
definitely. And I think that one thing that SBIRT doesn't touch on as much, but like MI does, is we don't want to get to the planning process too fast or like force people into a plan because they 100% just might not be ready to talk about this. So if we don't get here, it's okay. Maybe we spent, 15 minutes engaging with the patient and just exploring the pros and cons of their use. But that plants seeds. That's really important, and the seed will germinate, to continue the metaphor, and who knows, you might be able to have a conversation about it in the future, or another provider may be able to. So totally fine, we don't want to push them. So these 3 questions are really when we get to that point where they're giving you lots of change talk and reasons for change, and when you ask them that key question about what do you want to do next, maybe they said, well, maybe I could consider cutting back a little bit, or making some changes. So that's when it's appropriate. One note about offering ideas and recommendations, it can be recommended to, if you're going to give information to the patient, maybe offer a few things at once so it doesn't get them into this like dynamic of having to like accept or reject one suggestion that you're giving them. Like, well, you could just switch to Coke. Then they have to be like, I don't know. So more so it could be, well, some people decide to like alternate water. Some people decide to like just go out later so they don't have as much time to drink. Some people, have a soft drink instead.
So giving that menu of options is less of like, try this, no, try that, no. And it's more like, here's some options, which of those sounds good?
Yeah, and even saying like, I don't know if that's going to work for you based on your life, but what are your thoughts? Yeah. And then assessing confidence for change. So we talked about the rulers a few times. Molly brought it up too. So they talk about the readiness ruler in SBIRT. That's actually shifted a little bit in the last few years from the MI perspective, where there are a few different rulers, and oftentimes we don't go right to readiness. We can get kind of at different things when we use different types of rulers. So when we're early on in a conversation with somebody, we might first just assess importance. How important is this to you on a scale of 1 to 10? Oh, it's a 5? So why is it not a 1? What makes it a 5? And then as we move forward, we might start to assess ability. I think I mentioned this earlier. So how able do you feel to make this change? And that can be really helpful to assess when we're talking about like the next steps for change on the last slide that we talked about. Because if they're not feeling very able to make the change, we might need to spend a little bit more time on that if we can and help them brainstorm some strategies. And then near the end of the session, that's when we might choose to assess confidence for change, because we're really trying to wrap up and try to hopefully end this on a good note if we've gotten to this point. And if they say they're a 6 out of 10 confident and we ask them why they're not a 2, they're just going to argue for more change and give you lots of change talk and kind of, hear themselves talk about why they can do it. So if that makes sense to kind of do the rulers like that. A readiness ruler is not going to hurt you, but sometimes like, what does it mean, in my opinion, to be ready for change as opposed to those descriptors? Any questions or thoughts about that?
And then making a plan for follow-up. So first and foremost, using the teach back method. So it's not just, okay, so you're going to do X, Y, and Z. It's having the patient verbalize it in their own words. Assessing for readiness, and then also getting a little bit of talk in there. So what will tell you that this was helpful? Or what do you think the benefits? And then if possible, sometimes just based on the setting, or if you're in the EC and you're not able to follow up with folks, you get that. But if you're in a care office or in any other setting where you can make it work, figuring out when can we check in? Is it when you come in the next 2 weeks to get your blood pressure checked again? Is it, can I call you in a couple of weeks? So making that plan.
Yeah, for sure.
And if we're not checking in with them, considering who can you check in with?
Yeah.
Is it important for you to check in with one?
Yeah, can you bring us support system person? Yeah. Regarding the second one, we don't ask a lot of closed questions in social work. We are very driven to ask open-ended questions. It can be appropriate toward the end of a session to really try to get that commitment talk and ask a closed question, particularly one because you're trying to wrap up and get out of the room. But getting like a yes answer can really drive home that feeling of commitment for patients. So to comment on that. We probably have time to do these guys, right?
Yeah,
okay. All right. So these are not SBIRT videos, but they are motivational interviewing videos, which is, as we said, a huge part of SBIRT. So We're first going to watch this one and just notice what you see, and we'll debrief on this and then move forward talking a bit more about some clinical skills.
As a pharmacist, you will be expected to participate in patient counseling regarding various products that are available to patients, both over the counter and by prescription. Many patients who are speaking to you will be interested in improving their health, though some may not be prepared for the behavioral changes that are required to do so. This is particularly true among patients who speak to you about smoking cessation. As a result, it's important to keep in mind that the way you discuss this issue will have a big impact on how your advice is perceived by the patient. In general, it is not useful to confront or scold patients about their tobacco habits, as this may cause them to become defensive and may interfere with your ability to counsel them effectively. Watch what happens as this provider becomes more and more confrontational in her warnings about tobacco use and her advice to quit smoking.
Can I help you?
Yeah, I just got off work and apparently they're going smoke-free, so I thought I'd stop by the pharmacy and see what my options are. Some of my friends have tried nicotine patches and they say they don't work very well. I don't really want to quit smoking. I just need something to get me through the day.
So you want nicotine replacement, but you don't want to quit smoking?
Maybe like during the day nicotine replacements. Is that, do y'all have anything like that?
Yeah, we don't really recommend that. The idea is you would use the nicotine replacement to actually quit. So then you wouldn't be smoking at work, but you also wouldn't be smoking the rest of the time either.
Well, I don't really want to quit. I mean, I like smoking. I'll go like after work to have a beer with my friends. I'll smoke cigarettes. I mean, it's not really a big deal. Cigarettes aren't that bad. I mean, I know that it's popular to say that smoking is bad for you, but you know, I like it. I'm going to keep doing it.
Okay, well, smoking really is really bad for you. You know, it causes things like lung cancer, emphysema, heart disease.
Yeah, okay. Well, what are my options, you know? Assuming that I'm right, what are my options?
To be honest with you, you mentioned the patch. I can't recommend the patch to you if you're going to continue smoking. That can actually be pretty dangerous for you. In order to advise you about this at all, I need you to tell me a little bit more about your smoking history and how much you're smoking now.
I mean, I smoke barely a pack a day. I mean, I've probably smoked about 5 or 6 years now. It's not really a lot of cigarettes, but it's sort of hard to get through the day at work.
Okay, well, we actually consider 20 cigarettes a day to be a significant amount, and in fact, I would then recommend to you that you would start on the highest dose of nicotine replacement.
Sounds good to me. The more nicotine, the better. That sounds pretty great. Yeah.
There are some products that you could use to take away some of your cravings, and probably the gum would be the best option for you. It's not something you would continue to use continuously throughout the day, however. But gum is something you use just when you have a craving.
Oh, okay. Well, where's that?
Well, we have that here, but again, the idea would be for you to actually quit smoking.
Well, I'm probably not going to buy anything today. I mean, I just came by to see what my options are. Thanks for the input. I mean, do you have anything else? Do you have any other advice for me?
Aside from the gum, you could try the nicotine lozenge. That would be another option for you. Again, that's not something you'd want to use continuously throughout the day. The nicotine patch is the best for continuous nicotine replacement, but again, that's not something you can use while you're continuing to smoke.
Okay, well, thanks. I mean, I guess that helps a little bit. Maybe I'll be back later. Thanks.
Okay.
In this case, the patient came to the...
Great. Oops. Okay. Like, yeah. Whoa. There we go. So I feel like we kind of had a sense that maybe that wasn't right. I need initial thoughts on that.
Thumbs down, how do you think that went?
Yeah. Great. Yeah. Okay. So just keep that in mind. We're going to talk a little bit more about MI. Again, we've talked about it already. This is a very brief overview today. Like some of you I know I recognize faces have been to workshops like where you do like 16 hours of motivational interviewing, and that can be like a really good foundation, and people have taken courses. Doing a 45-minute overview of motivational interviewing is just skimming the surface, so giving you just with that caveat, but we're just talking about like the spirit and some basic skills that could be helpful if you're not already familiar, which we know that a good amount of you already are based on what you shared. So this will be a review. So what exactly is MI? This is the practitioner's definition of MI. It's a person-centered counseling style for addressing the common problem of ambivalence about change. We've talked a little bit about ambivalence throughout the day-to-day, particularly the pieces when we're talking about the pros and cons of your use, right? So it's really normal to feel two ways about something. And I think we all can speak to things that we feel two ways about. Like, I should exercise more, I should go to bed earlier, but that yes, but feeling is just really, really common, part of human nature. So it's totally normal. One interesting with ambivalence is that if we look at it in the right way, it can actually be a good thing. So jumping back to that, the stages of change model, when we're thinking about the pre-contemplative person that like doesn't even want to talk about it or feel like they have any issue, they're not even at the point yet where they have arrived to ambivalence. So if somebody is ambivalent about a change, that means that they're already taking steps to make that change, or kind of thinking about making that change, if that makes sense. So they've moved a little bit about that along that spectrum where they're thinking two ways about it. I think sometimes as providers, we can feel a little bit stuck and frustrated when somebody is arguing against making that change. Like, but I really like smoking and it feels really good and it gets me through the workday. But if they are voicing two sides, then think of that as a positive thing. The other thing about ambivalence is it can be really, really sticky. And while it can be moving us for a change, people can get stuck there for a very long time, whether that be weeks or years and years and years. And oftentimes folks need a little bit of help to understand why it is they want to make that change and how they can do it. So that's our role as the guide. And I also want to talk about how one thing that's really interesting is, so we talked about how people are usually intimately familiar with both sides of an argument. It's not new information to them. And that it's really common for people to kind of do the debating, right? So if we give one side of the argument, it's common for people to say, yeah, but, and argue the other side. So one interesting thing about us as humans is that we are more likely to believe what we hear ourselves say than what we hear other people say. So what happens if we give people that thing like, well, you need to quit smoking, and then they argue the other side, they're going to start to believe the other side a little bit more. So if we take the approach of talking to them about, what are, eliciting the reasons for them to change, then they're going to believe it more because they hear themselves saying it. So just an interesting thing about humans. This is Leslie and Ann.
So we talked about the spirit of MI earlier. The patient has all the strengths, right? It's our job to partner alongside of them, accept them for where they're at, show that compassion, and evoke their reasons for change.
These qualities, we went through them already, but people with these qualities that exhibit these in their clinical work or generally with partners, families, whatever, they're often drawn to MI because it feels really right to them. Like, oh yeah, this just makes sense. This is how I want to talk to people. This is how I already kind of do. It feels good. But if folks are coming to MI where they don't have like the clinical training that we have in this room, or maybe don't have these qualities innately, they can go through MI training and learn kind of some simple clinical skills and strategies to use. And actually these qualities will kind of like come up in their practice, even if that's something that isn't innately part of them. So we'll go through like some of the basics you can do. And if you do those things, you'll be showing partnership, acceptance, compassion, evocation kind of naturally. So we talked about supporting autonomy. The decision to change is always with the patient, and they're the expert in knowing how to proceed. There's this interesting theory, again, to talk about human behavior called psychological reactance, which some of you might be familiar with, which essentially is sort of like that teenager effect, where if we tell somebody that they're not allowed to do something, what are they going to do? Think about a teenager. They're going to want to assert their freedom. So if we're telling somebody to stop drinking, it's really natural and normal for people to be like, no, you can't tell me what to do, and assert their freedom. So something to keep in mind for how we're talking to folks.
So ORS, who in the room has heard of ORS, using ORS? Yeah, so a big foundational piece of motivational interviewing. Always trying to stick with open-ended questions. So not, is your drinking bad for you? But more so, tell me more about things that you don't think about your drinking. Affirming. I love affirmation. That's like all I do all day. Really reminding folks and highlighting those strengths, even in times where it doesn't feel like that person might not feel like they've had a lot of strength. And even just going, I love the basics. Thanks for showing up today. You showed up today. That's so courage. Thanks for talking about that. That takes a lot of strength. Reflection. So can range from the simple of you think that there are some good things and some bad things about your drinking, all the way to open-ended or double-sided reflections. So things like, on the one hand, do you like going to the bars with your friends because it's fun and it's a way for you to socialize? And on the other hand, you're a little worried about the cost. It's starting to add up. All the way to the really fun, amplified reflections. Like, there's absolutely nothing wrong with your drinking. Just a straight face. And then summarizing. So taking what the patient has told you and just giving it back to them.
Yeah, absolutely. So, or you can spend, on our recent workshop, I think we spent 5 hours going through each of these skills and practicing and role playing. So you can really get into these. So this is a very brief overview, particularly reflections. Like even as, skilled social workers, it can be helpful to like hear other people's reflections and practice and do worksheets and watch videos. So you guys have the opportunity to do that, and I always find it helpful still. Okay, so sharing information the MI way. So we talked about elicit, provide, elicit already earlier in SBIRT, and this is one thing that Teague and I feel like it's really important to integrate into SBIRT, and it's not explicitly mentioned in the model, but we think it's very important, and I think definitely works, and we know that MI is evidence-based, so let's integrate it. So pretty straightforward. So we're finding out what the patient already knows about something. So, whether or not that's substance use, like even if somebody's coming in to talk about their depression, like, what do you know about treatment for depression? And kind of pulling out what patients have tried or what they know about what they could do. And then saying, okay, so you mentioned that you've tried doing some exercise, you've tried eating healthy, you tried some medication that didn't so much work for you. Would you like to know more about other medication options that are out there? Whatever. Asking permission to share information. Again, indicating they can choose to accept or deny the information, and if you can, giving a menu of options. And then at the end, eliciting. So those are a few questions that can work at the end, but use your own style. Questions about this? I feel like we talked about it already.
We really like this model because a lot of the times in our work there is information that we need to give to the patient. The patient can't walk out of our office without knowing something, just based on what we do and what our roles are. But this is a really nice way to give them that information, but make it less of a lecture and more of a conversation experience.
Oftentimes, this can be one of the most valuable things that people walk out of like an intro workshop with, particularly if they don't have a clinical social work, mental health background, like providers that are used to like telling and telling and telling. This can be like a huge tweak in practice, but could be received so differently by the patient. Interesting. All right, so we're going to watch the second one to drive home MI, just to get the feel for it. Should we do that? Thank you. See what you notice.
Watch what happens this time when the provider listens to what the patient is saying, empathizes with the situation, and attempts to work with the patient to find a solution that fits his needs.
Hi, can I help you?
Yeah, I hope so. My workplace has just gone smoke-free. I'm not very happy about it. I'm going to keep smoking, but I was wondering if there's anything that can help me like get through the day, so I can, go get my beer and smoke cigarettes after work.
So your workplace is not smoke-free and you're not too pleased, huh?
No, I'm not going to quit smoking. I like it. It helps me relax. I don't see what the big deal is.
Okay. Tell me a little bit about how smoking fits in your day. It'll help with the.
I smoke a little less than a pack a day. It's not too bad. I've probably smoked for the last 5 years, but I could quit if I wanted to, but I don't really want to.
Okay, so you feel like right now smoking is a pretty important part of your life. It's not something you're ready to change, but if the time came when you did decide to quit, you feel pretty confident that you could go ahead and do that.
Sure, I could quit.
Okay, what makes you so confident?
Well, I mean, I don't see why I couldn't. Although I have not ever tried to quit. It's just something that I do for fun, you know, on breaks at work, in the morning, and after work.
And so, in terms of a readiness to actually go ahead and make a quit attempt, where do you think you fall on the scale of 1 to 10, where 1 is I'm not considering it at all, and 10 is I'm definitely ready and want to quit?
I'm probably 2. I haven't even thought about quitting until this great announcement at work today. I'm totally not going to quit smoking.
Okay. What made you say 2 instead of 1?
Well, I mean, anything's possible. I mean, I guess I can maybe do it. Is there some, I mean, are there things I can try that would make me like want to quit smoking?
Well, there are a lot of products available now that can actually help you curb that urge to smoke. We have products that can help to replace nicotine, which can help decrease withdrawal symptoms that you might experience when quitting or cutting down, and also some medications that your doctor could prescribe for you that might take away even some of the desire to smoke.
Okay, well, that's good information. I mean, I'm not going to do anything today. I just need to know my options. But that's encouraging. If I decided to quit smoking, I do have at least tools to help me quit.
Sure. And back to that scale you mentioned, you said you were a 2. What do you think it would take to move you up to a 4 or a 5?
I don't know. I guess if my friends, like, if one of my friends decided to, like, quit with me, that would probably help too. But all my friends love to smoke, so I don't see that happening in the near future.
Sure. I wonder if now that your workplace is going smoke-free, if there will be some people at work who are planning to quit.
That's a good point. I hadn't really thought about it. That's a good idea. Yeah.
Okay. Well, it sounds like you're really here just for information today. I'm happy to help you pick out some of these products if and when you decide that the time is right for you.
Okay. Well, thanks a lot.
This time, the provider attempted to counsel the patient regarding tobacco cessation with it.
Okay. What did you guys notice that was different about that one?
Oh, we flip them. Filter.
Oh, okay. Thank you.
What was different?
What was MI about that, or more collaborative in general?
And how did that change the interaction? What else?
He hadn't thought about other folks.
I think she did come up with Florence too. First time she very clearly had to spend her phone out. Yeah. And she was clearly like talking through it with people.
And kind of like in SBIRT, like we've talked about, this isn't him saying, you know what, I'm gonna quit today. Sign me up, like I'm done smoking. You fixed me. But it is planting that seed and that non-judgmental conversation that he's had. He would be more likely to go back. Hey, I've got some information about my options, and it's not building up that defense of like, oh, another person who wants me to quit. I'm never talking about this again.
Yeah. So if we're thinking about like what was their plan, like they didn't nail down a hard fast plan, but really it's that he's gonna walk away and consider his options, and you could come back and talk to her more about it. And that's an okay plan. Yep. I also noticed just that she kind of indicated his autonomy, you know, if you decided that you wanted to quit, you know, if you would want to come back, language like that could be helpful.
I think that's the word support.
Choose what?
The workplace option.
Yeah, good point.
Drawing on those environmental factors.
Yeah. Great. I think for time, we'll move forward. Thank you. So just to kind of, I think this is wrapping up our MI section, but so these 5 questions can be kind of interesting. So Miller and Rolnick, who are the founders of MI, talk about this in the most recent book, that these 5 questions can foster the spirit of MI. And oftentimes when we're doing a workshop with folks, first we'll have them go through an exercise where they try to persuade somebody to make a change and see how that goes and how that feels. Then we'll have them, you know, pair up with their partner and ask them these questions. And oftentimes both the practitioner and the patient talk about how much better it feels and how they feel listened to, and it feels more collaborative. And I even heard practitioners talk about how, like, gosh, I didn't have to talk nearly as much as I had to talk in the other one where I was trying to persuade them to make a change. You know, they were doing most of the talking, which is great. That's what we want. So these can be kind of interesting, and they've done, you know, a little bit of study on this, and people that are on the other end of these questions report feeling kind of the same feelings of like openness and collaboration and partnership as a result of these questions as they do from a full session of MI. They can be pretty powerful.
So thinking about trying to incorporate perhaps one of these questions into your daily practice. I give myself little MI challenges. Like, today I'm going to try to double reflect with every person I talk to. Thinking about how can you incorporate something like this?
So if you want to learn more, again, workshops and longer trainings are really helpful. I think even when we're skilled in MI, doing practice is just so helpful, like doing boosters and things like that, because drift is really natural. So getting a refresher is like, oh yeah, I should be focusing on that. Watching and listening to the expert tapes and videos like on YouTube I think that can actually be really helpful. And there's actually some videos on YouTube of like Bill Miller doing motivational interviewing. He's one of the founders, and he's very skilled, and it's really nice to watch. I think some of you have probably seen those before. And then these are a couple of texts that are really great. So the third one is their most recent book. I'd recommend that highly. It's very readable. And then the third one is a great workbook for doing like worksheets to practice reflections and affirmations. And you can even build work groups around this work group and kind of work through the worksheets together and talk about, you know, different skills amongst yourselves. So yeah. Also a really good thing you can do if possible is like record your sessions and listen back to them, but that's the key, but not everybody has the ability. Okay, so last part of SBIRT. We got about 20 minutes, and this part's pretty quick, so want to take us away?
Yeah, so the RT in SBIRT is that referral to treatment. So not every patient just needs a brief intervention. Some folks need to have a bit of a higher level of care, so that's that referral to treatment part. So in this section, we'll walk through the referral process. So assessing what level of care they might need, talking about access, and talking about barriers to patient.
Yep.
So lots of different options. How familiar, if we look at this, how familiar does everyone feel with these terms? Or should we think about that?
Any questions about what any of them are? We're all social workers in the room. Okay, great.
Okay, so lots of options based on acuity and also patient willingness to want to engage in them.
Absolutely.
Another nice feature in referral to treatment is acknowledging multiple pathways to recovery. So we have your traditional 12-step groups that have really expanded over the years. We have Alcoholics Anonymous, Narcotics Anonymous, we have Dual Recovery Anonymous, which is for co-occurring mental health and substance use conditions. And then we also have what are termed mutual support groups, but you can just think about them as non-12-step support groups with different flavors to them. So here are just some local options. We have Refuge Recovery, which is coming from a Buddhist standpoint. We have some secular recovery options. Smart Recovery, they call themselves a scientific reason group. Women's focused, but again, it's not a 12-step. And then there's also other things. So in this area, we have recovery infused yoga. So there are a lot of options. It's not like, okay, you need to go to this 12-step group and meet 5 times a week. There are a lot of different options based on what that patient's looking for and what they're ready for.
Right. So again, not an exhaustive list by any means.
Yeah.
But
And in the resources that we'll send out, Home of Revisions, they're really fantastic multiple pathways to recovery sheets with lots of different options. So we'll be
one thing to note here is that most of these are abstinence-based, so folks who are looking for harm reduction can sometimes have a harder time going to these types of groups, but there are harm reduction options as well, including Home of Vision, take the harm reduction standpoint, at least locally. So pharmacotherapy, that could be another option for treatment, and we talked about addiction psychiatry briefly on the other slide. I'm not going to go through all of these. I'm sure a lot of these medications look familiar to you guys, but these are kind of the MAT options that are out there right now. one thing that was kind of interesting to me is that methadone is the only drug used in medication-assisted treatment that's approved for women who are pregnant or breastfeeding. Good to know. And then naloxone, probably have been hearing a lot about that in the news. That's the overdose prevention drug, and they're training emergency responders that, and even prescribing it to patients. Get a prescription for opioids. So, again, not spending a lot of time, but it's an overview.
And referral to treatment selection of facilities. So first, we determine the level of care. Lots of the folks that we work with are appropriate for outpatient care. So something like counseling or even an outpatient, typically provided by a behavioral health practitioner. And then maybe even if they're just going to outpatient care, they might need to start in a detox setting, just based on what else is going on, level of any other conditions that they're experiencing. And then, I mean, this is all kind of what we do every day, right? Is thinking about what else is going on with the patient. So just preference, cultural context, family support, transportation costs, service match. It's also really important that we are working in a team, so keeping the team and other members of the team involved.
Yeah, and I think one thing to note here, we had the MAT slide before this, is just considering if a patient is or wants to be on medication treatment, choosing a service that's going to match that in terms of like beliefs about MAT, about an issue right now, and will that service support it? And then also thinking about like religious beliefs in terms of like 12-step versus social support groups. Sometimes there can be times at play, et cetera. All things we do as social workers. So accessing care. So these are kind of like the 5 steps for accessing care. I think a lot of us, place referrals all the time. So we're assessing the patient's readiness, working together to select a facility based on the things that we just went through. When possible, completing a warm handoff. I felt like maybe that was the one to highlight. So if we can, contact the facility with the patient together, if they're willing to do so, and kind of talk to them and really be a part of that referral, research shows that can impact whether the patient follows up and actually engages with services. I think, we've all been guilty of being busy and getting a phone number sometimes, but it's a good thing to keep in mind. Determine your role and plan for ongoing communications with the facility, if at all, get the patient's consent, get releases signed if appropriate, and determine how often you'll be in touch with them. And then confirming a follow-up plan with the patient. Again, if at all, it might be the ED or it might be primary care where you're coming from. So when will you be in touch with them? And if there is a wait list, which we know that there often is, what's going to be your bridge plan? So brief intervention can be part of referral to treatment or brief treatment. So if you need to see the patient short-term in your setting and work through some of the other techniques we've gone through today, that might have to be part of it if it's appropriate. Yeah. Great.
And navigating barriers as well. Insurance is huge. So considering insurance coverage, medication coverage, being aware of what is out there, who is accepting what insurance, being aware of free options, prescription assistance, things like that. Transportation can also be a huge issue, so being aware of the resources in your area. If you're not here, we'll send along some information that we have, but if you're outside of Washtenaw County. And then also, again, when it comes to barriers, keeping in mind the patient's needs and matching them with something that is appropriate.
Did we miss any big ones that stand out to you guys in terms of barriers to accessing substance use disorder treatment? Guys, do this work. These are kind of the big ones I felt like. Okay, great. Shout them out if you think of any. All right. So I don't know if we have time for this part now. So we kind of wanted to do a knowledge sharing because I feel like we have a wealth of information in this room. We have lots of clinicians, lots of social workers. So we kind of did like a bare bones list here in terms of what's available in Washtenaw County, and then I just put SAMHSA for general resources right now. There are obviously way more like AA's website, different things like that. What we could do is maybe just send out the Home of New Vision handout for the multiple pathways. Are there any glaring resources on here that someone's like, I love this resource and I really want to throw this on here or share? Anything? Whether locally or a general resource.
Yeah.
They're, so we're on chronic care, illicit drugs, on pregnancy, and they take medication as
Great. It's called Partnering for the Future? That's great to know. Thank you.
Convoy vendor.
Okay.
Yeah. Are you getting something out?
Yeah.
Yes.
Yep.
Yeah. Is that an okay way to describe it? Perinatal MAT and support probably? Okay.
What else? Any other fantastic places that aren't on the list that we should all know about?
Oh, yeah.
Oh, sure.
Great.
Yeah, they do MAT now, right? Yeah.
And you don't have to have your card on the
You can just go to the site.
And even if,
Yeah, no cross-outs. Great. For those who are joining from CHCs, there are a lot of CHCs throughout Michigan that are doing MAT now too. It's a lot wider. Like some of our partners have addiction psychiatrists there that are practicing. So great.
Corner Health has an addiction. I know the psychologist site for Washington County.
Great.
Ages over 15 to 25.
Okay. I'll say maybe adolescent.
It's through a St. Joe partnership. Caveat, it's really good in the weight sucks, but
Sure.
Oaktown has an expert person who will.
Okay.
and you know that like Healthy program, that's at Riverwood, is open to like all faculty and family members, like it is. And they don't bill insurance. Yeah. Health education. Yeah. But that can be really like short term. It's really MI based. Yeah.
Okay, like the EAP program, is that what you're talking?
No.
Or no?
It's just.
Oh, I,
Yeah.
Yeah.
yep.
Yeah. And maybe helping them. Yeah.
Oh, it's okay.
Yeah. Very low, like, very low risk, like, needed.
Okay,
Yeah, sure.
great. Wonderful. Thank you. I learned a couple things.
Having this many professionals in the room who are doing really good work all the time, we knew that we needed to pool our resources.
Right. Great. Obviously, there are more general resources than just STEM. Looks funny now. Okay. Google, the internet is your oyster. Okay, so just to kind of wrap up, we've got about 10 minutes left. So challenges of SBIRT implementation, there are going to be way more than we note here. I think one thing that I've already picked up on in addition to these things is that we have a variety of different settings that we all work in, and everybody looks different in terms of space and time we have with our patients and follow-up. So we kind of do the best we can. We touched on this. And know that it can be an adaptable model. It doesn't have to be tied up with a bow. So lots of workflow redesign, particularly when we're talking about the screening piece, and, working with your sites to see if it is appropriate to do screenings. Again, universal screening is a big topic. So, bridging that conversation with your clinic manager and leadership could be a way to go, depending on, what feels right to you guys and your sites. But in terms of learning and practicing a new skill, so, if you're not familiar with MI, doing the brief interventions can feel very new and very different. So just keeping up on that and seeking out additional training. And then I just put changes in policies, resource availability, just because the whole climate is always shifting in terms of what's available for referral to treatment. So it can be a challenge to keep up with everything and get access.
So benefits, like I said, I love affirmation, so great benefits. Reduce healthcare costs, having an evidence-based practice to utilize. Sometimes as social workers, it can kind of feel like, what are we doing? This is evidence-based. We have a model that we can follow. Working as a member of the multidisciplinary team, and being right there with the docs and the nurses and everyone else who has that patient interest in mind. As well as you see the potential to make a real impact in people's lives, which is probably why we're all in this field.
Mm-hmm.
And another benefit to SBIRT is that it is a billable service. Mm-hmm. So thinking about how that might be incorporated too.
Yeah, I think regarding the evidence-based practice too, like, I wonder, like, if a lot of people realize, like, oh, I am doing SBIRT, like, after seeing this training, didn't raise your hand, like, so we kind of already have that gut feeling that what we're doing is working on a daily basis and we're seeing positive change in our patients, but to know that, like, there's evidence behind it and we can say, yeah, I am doing an evidence-based practice, and, just talk to our providers about that, our leadership, like, it doesn't hurt.
Yeah. Just kind of tying together a lot of the things that we're already doing.
Yeah. So next steps, what can I do? So accessing the screening tools, like we said, we'll send out some information to you guys. They're all available on Google and SAMHSA. Substance use education tools, if it feels appropriate to you, feel free to access those via NIAAA for kind of getting those little cards available. Make your own. You can even make the little rulers to use as tools if you want. Seek out further MI training if appropriate. Practice brief interventions. These are kind of the things we touched on today. Asking permission, elicit, provide elicit, acknowledging ambivalence, and really finding out why the patient wants to change and helping them develop their own change plan. That will be success. And then I think we're always doing this, but creating and updating your local substance use disorder and recovery resource list. I know there's a lot of good resources in the Department of Social Work for that. So, oh, one thing we wanted to touch on before it was over. There's this cool app, and it's free. And I just found it this week, actually. It was created by the University of California, San Francisco, at UCSF is? Yeah. So it was funded by SAMHSA. It's kind of neat. So it's a full SBIRT app and can kind of be like a resource in your pocket if you wanted something to reference. It has it explains the basics of what SBIRT is, different screening tools that you can access, and it even has like sample scripts for how to talk to people through screening in sort of like a supportive fashion, and kind of works you through like what is harm reduction, ways to cope with cravings, different things like that. So lots of good tips. Even talks about like pharmacotherapy and has like some dosages and medication names on there. It's not totally up to date, but pretty good. So download that for free on your local app store if you want to check it out. Okay, so I think we have 5 minutes for questions. If anybody has any questions or remaining thoughts after that 3 hours of whirlwind information.